Okay, well, thank you again, everybody, for your time this afternoon. Again, this is Matthew Menendez with White Plume. This webinar, just to make sure everybody's in the right spot, is designed specifically for orthopedic practices. We're going to be talking about some of the things that you got to be careful about in this new post-ICD-10 world. Right, I'm sure everybody is glad to have October 1st in our rearview mirror. For a lot of us who've been working on ICD-10 for a long time, there's a temptation to view October 1st as the finish line. And yes, there was a lot of hard work that goes into that date, but I think we correctly need to look at October 1st as the starting point for ICD-10. We are still dipping our toes in, getting our feet wet, and discovering about this new world of ICD-10, and there's still a lot of changes to come. So I hope that this webinar will be helpful for you in starting to think about what some of those changes will be and how to make sure your organizations are prepared to be successful. So what I hope to accomplish, give you some background information on ICD-10, what we've seen so far, what makes ICD-10 difficult for orthopedic practices, what's uniquely difficult about that here in the United States. And what we're going to see is a lot of people seem to have had a lot of success here in the first few weeks after ICD-10 go live. That is certainly a good thing. There has been no catastrophic industry-wide meltdown, and that's certainly something to celebrate. However, I don't think we can raise the victory banner just yet. You know, we still haven't seen claims fully adjudicated, and we're not going to see the full impact of ICD-10 for at least another 12 months. And so one of the things that you need to guard against that we're going to talk about is getting into some bad habits. Because if you have a false sense of security that leads to bad habits, that's going to lead to more painful changes down the road. And we'd rather start out on the right foot if at all possible. The next thing we're going to talk about are what are the big risks? What are the big impacts that orthopedic practices are going to deal with as we continue to roll out ICD-10 over the next 12 months. We probably haven't seen much of this yet, but one of the big risks is to physician productivity. And we're going to talk about what that looks like, how it happens, what some of the warning signs are, and how you may be able to prepare to protect against that. And that means if your doctors aren't taking care of patients, nobody else in the practice is. If your doctors aren't generating revenue, nobody else in the practice is. If they're not doing those two things, they're not going to be happy. They're not going to be satisfied in their work. And if they're not happy, nobody else is. So we have to protect our doctors' time and their productivity. We're going to talk through that. But right behind that is our revenue cycle. Our revenue cycle efficiency. How do we turn those encounters into cash? How long does that take? Is our AR days lengthening because of denials? We're going to talk about that piece of it as well, because you have to do both if you want to be successful in this transition to ICD-10. We're going to talk about some of the things to look for. Again, some of the warning signs, some of the things that may point to a coming problem, and then I'll make sure that we leave time for questions and answers at the end. Okay, but what makes ICD-10 hard? What makes it difficult? What makes it challenging, not just leading up to October 1st, but now that we're past that date, what makes it challenging in the year to come? The first thing obviously was it was a one-day conversion. A lot of people talked about it like Y2K, right? And again, I would encourage you to think of that as our starting point, not our finish line. ICD-10 began on Thursday, October the 1st, but we're going to be dealing with that for a number of years. We dealt with ICD-9 for 30 years before finally moving over to ICD-10. We're going to be working in ICD-10 for quite some time, and we don't want to have that false sense of security, right? A lot of the industry-wide reports that we have heard have been good news, right? We were able to capture all of the data. Our PM vendors were ready. The clearinghouse could accept the claim. The payer could accept the claim. All of those things are very good news, but we can't declare victory yet. there are still things that we have to do and that will continue to change. And one of them, another thing that Medicare has done that I think makes this more difficult, is the confusion around unspecified codes. Right, I'm sure everybody read the press release, the announcement that was a joint announcement between CMS and AMA over the summer, where they were offering basically a 12-month grace period, saying they would not deny claims only because they were unspecified codes. Meaning, if the code was in the same code family, that they would make sure that the claim got paid correctly. Now, that's Medicare only, and they said that they would do that for the first 12 months. This is one of those areas where you have to make sure you're not setting up a bad process, a bad habit that you're going to have to change later. It's one of the things that makes ICD-10 difficult. Now, one of the things that I think makes ICD-10 particularly challenging here in the United States is that it's a big change for our physicians. Now, many doctors may have had very small changes thus far, but there are more changes coming. And the big risk for our doctors compared to physicians in Canada or Australia or England when they move forward with ICD-10 is our doctors are not government employees. We're paid in a fee-for-service world today, paid off of your productivity. And they cannot slow down to deal with an unfunded mandate like ICD-10. The other part that makes this tricky is a lot of doctors are looking for the fastest, easiest way to deal with ICD-10, and they may not be fully trained. They may be trying to cut some corners, and that hasn't had a negative impact to them yet. And so that reinforces the thought that says, this isn't my problem. Everybody else downstream can deal with this, and I can keep doing things the exact same way that I'm doing them today. Got to watch out and make sure that what you're doing today is producing the type of outcomes that you need for your revenue cycle and ultimately for your physician productivity down the road. And we're going to come back to that. But the part that I think makes ICD-10 the most challenging over the next 12 months is what's at stake. We've had a lot of change in our industry over the last 6 or 7 years, a lot of government-driven change. Right? Think about all the programs that have been rolled out with PQRS and e-prescribing and meaningful use, and now ICD-10. The first three that I mentioned, PQRS, e-prescribing, meaningful use, those are all optional programs that included incentive payments on your Medicare or Medicaid reimbursement, and they were phased in over time. Then ICD-10 doesn't look like that. ICD-10 is mandatory, not optional. ICD-10 has no incentive payment. ICD-10 is immediate, not overnight. Immediate, not phased in. That's what makes it difficult. And what's at stake is it's not a 2% reimbursement bonus or cut. It's 100% of your cash flow is at risk if you don't do ICD-10 correctly. Now, the good news is that's not all immediate. Right? Medicare has said that they're not going to deny claims for unspecified codes for the first 12 months. Some of your private insurers will probably take a different path than that. They'll be on their own timeline. So you get to stagger that a little bit. But you've got to be careful that you don't set up a bad process that's going to create bad results. All HIPAA-covered entities obviously have to move to ICD-10, so all of your payers, not just the Medicare, Medicaid entities, right? But what makes that even more challenging is it's not just about getting an ICD-10 code on a claim or even a code in the right family. You've got to think about the hoops and hurdles you have to jump through to get a claim paid. And not all payers do that the same way. Blue Cross wants it one way, United wants it another way. We're going to continue to see that in the ICD-10 world, and we'll continue to see that change in the ICD-10 world. It's not a stationary target. You've got to keep up with those changes in ICD-10 just like you do in ICD-9, right? But again, If your payers are paying you for these unspecified codes today, that's something that can create some bad habits. I'll show you what I'm talking about. This false sense of security that we get, we've already seen some results very quickly. On the first day, you were really able to see, even if you had not done testing prior to this, is my PM vendor, is my EHR vendor ready for this? Have we installed all of the updates? You would have known on day one if that wasn't working very well. The good news from across the country is most people were in pretty good shape there. There weren't a lot of problems reported early on. Now, there could have been some problems that people had they didn't want to share with the rest of the community, and they're dealing with that one-off. But I haven't heard a lot of clients, I haven't heard a lot of people in our space talking about challenges that they had with those types of vendors. And so the next thing that we get to is obviously submitting claims. Can my clearinghouse, can my payer interface with my practice management system and make sure that that data flows through ultimately to the insurer? Most people have been successful there. The MGMA town hall meeting that was done in Nashville had a lot of people from the payer community, and the evidence that they have not seen a significant uptick in rejections as a result of ICD-10. Again, that's good news, right? That means we've avoided what seems like the doomsday scenario of the payers aren't ready. They didn't take the time to make sure that their systems were prepared and able to receive and process those claims. We seem to have success there. The question mark is still what happens when they adjudicate those claims. When they start to look at the quality of data being sent by the provider community, what is going to happen? Are we going to see denials increase as many people have predicted? Are we going to see them pay almost all of those claims? Or are they going to be denying certain claims for lack of specificity? How are they going to handle that? That remains to be seen. And as those results start to come in, that's where we are going to see how well prepared these practices are for ICD-10 and where you need to make changes, where you need to make modifications. Again, as we look out over the next 12 months, there's going to be a lot of changes that you're going to have to go through there. But the main point of emphasis that I would have for you is focus on the two big items, the two big risks associated with ICD-10. Risk number one is a decrease in physician productivity, right? We cannot have that. That is an unacceptable outcome. Our doctors did not go to medical school to be coders. That's not what they're interested in. That's not what they're best at. That's not what our patients want them doing either. We have to take care of our doctors, make sure that they can continue to see the current patient volume that they see today. The other place is revenue cycle efficiency. And when I say revenue cycle efficiency, what I mean is how many people, how many labor hours does it take for you to get your claims paid correctly? Because if you have to hire more employees to work in the revenue cycle area, that's a bad outcome for the practice. If those employees have to work longer hours and spend more time overtime, that's a bad outcome for the practice. If claims aren't getting paid at the same rate, it's taking longer to convert those encounters to cash, that's a bad outcome for the practice. You've got to make sure that you do both of those things in your transition to ICD-10 and as you make changes to your process, right? Think about the process. This is probably, most of you aren't seeing either of these big decreases right now. And that's the good news, but that's what we're holding our breath on to wait and see what comes back from the payer. Because what happens is, whether you do this with cheat sheets or encounter forms or code books or your EHR, the basic workflow process, it starts with the physician. Right? They're the person that was treating the patient, who's in the exam room with the patient, at the very least, responsible for their documentation, and somebody else can code or do the billing work from that, right? And billing goes downstream. We've already seen success with the PM system and the clearinghouse and the payer. But what's going to happen is when the payer starts to adjudicate those claims, that's when we go back to the top of this process. and where the big risks are going to be, particularly for orthopedic practices, are in those unspecified codes. You know, a lot of people didn't focus on that on the front end, aren't focusing on that now, you know, the unspecified codes in the code set. What got most of the attention were some of those crazy codes, right? This is probably the most infamous ICD-10 code that people like to make fun of, right? And you can look it up in the code book. It's a valid code, B91.07XD, that flaming water skis. Now, what most people didn't tell you is, believe it or not, that was a valid code in ICD-9. You know, that external cause code, it was an E code in ICD-9, and you never used it. Most practices do not use external cause codes. In fact, CMS has already come out and said if you weren't using external cause codes in ICD-9, there's no new national requirement for you to use those in ICD-10 either. They're a distraction. Right? A lot of people like to make fun of them and talk about some of those crazy codes, but they never actually used them. And I think they serve as a distraction for most people away from one of the more silent killers. And what I'm talking about are obviously unspecified codes. These exist in ICD-10. You can be very unspecific. You know, T14.8, very, very unspecific. You could do that in ICD-9 as well. The difference here is that in ICD-9, there were not negative consequences associated with using the unspecified codes. In ICD-10, there are. There are two big risks to unspecified codes in ICD-10, a short-term risk and a long-term risk. And they both have impacts on physician productivity in the revenue cycle. So let me explain. The short-term risk is that the claim is going to get denied. Now, you may not see this day one. You may not see this in 3 months. It may take 12 months before you see this for the first time. But it's going to happen. And here's why. Here's why. The payers, why have they advocated for the migration to ICD-10? Why did they lobby Congress to move forward with ICD-10? Why did they invest millions of dollars to rewrite their adjudication algorithms for ICD-10? It's because they want the more granular detail that's available in the ICD-10 code set. They want the more specific diagnosis codes to understand what's going on in their patient population. And if the provider community does not give them that data, they are going to deny the claims. Now again, Medicare has said that they won't do that for the first 12 months. We have not heard any public statements from Blue Cross and United or anybody else. You know, the suspicion is that they may not wait so long. But we're going to see that in the short term. And you need to make sure that your process is either handling that today or that you're prepared to make the necessary adjustments quickly when that happens. The long-term risk of using those unspecified codes is ultimately the government's trying to transition us away from the fee-for-service model. Right? Now, this is going to take some time, but they're trying to transition us away from fee-for-service, moving towards a outcomes-based reimbursement, pay for quality, pay for performance model. And in that world, it is all about the expected outcome versus the actual outcome. The expected outcome compared to the actual outcome. And the way that they measure that expected outcome is based on the diagnosis codes. How sick is your patient? How do the diagnosis codes interrelate? How severe is the illness? And you need the more specific ICD-10 codes to show how sick your patients are, to maintain and maximize your reimbursement in that world. That's the challenge. That's the concern for practices who are using unspecified codes. Many practices are probably using unspecified codes and they're not even aware of it. Many people were using it in ICD-9. Let me show you a common example in orthopedics. Okay, the first example is using 71596. Every orthopedic practice uses this code, the osteoarthritis of the lower leg, right? Now, if you take that and you put that into a conversion tool, right? If you look up what does that convert to in ICD-10, if you have it listed on a cheat sheet, the corresponding code, right? The code that most people use is M17.9. And the problem with that, M17.9, is osteoarthritis of the knee, but it's unspecified. It's unspecified as far as the type of osteoarthrosis. It's also unspecified as far as which knee are we talking about. It's a valid ICD-10 code. But what are the payers going to do if you saw a patient that had knee pain, that had osteoarthritis of the knee, but you didn't know which knee it was? Are they going to pay that claim? Probably not. Probably not. And so for people who are using a conversion tool like that, you've got to be careful about what are the results that it's producing. For the people who are using a cheat sheet or doing it through an online tool, what is the correct code that you should be using, and are you producing those results today? Right? If you go look it up in the code book, you'll see M17.9 down at the bottom is a valid code, but you'll also see those other ones above it. Those are the more specific codes. But you've got to be careful. Is my doctor going to take the time to read through all of those choices to choose the one that's most specific? You know, if you're using M17.9 today and just using that to replace 715.96 in your old process, you know, that's great. You think about your process, it probably looks pretty good. ICD-10 seems like a non-event to your physician. You used to use one code, now I use a new code. I don't even pay attention to what the code is. It's still osteoarthritis of the knee, right? The billing team gets that, not a problem. They can put it into the practice management system. They can fire off a claim. The clearinghouse accepts it as a valid ICD-10 code. The payer accepts that as a valid ICD-10 code until they adjudicate the claim, and what happens? That claim is ultimately going to get denied. Now again, we're probably going to get some grace on this in the early days. You're probably going to see that claim get paid correctly for the first month or 3 months or 6 months or maybe 12 months in the case of CMS. But eventually, when that claim gets denied, what's going to happen? Here's where you're going to have a process that's really going to be painful in the organization. This is what we want to try to avoid, right? And we say, okay, well, I've got my billers now going back to my doctor and saying, I need you to be more specific. Can you tell me about the type of osteoarthritis? Can you tell me which knee it's in? Maybe all of that's already in the note, and it's not slowing down the doctor, but it's slowing down the billers and coders. It's slowing down your cash flow. Those are the problems that we're trying to avoid. We want to be proactive there, not reactive there, right? You'd rather start off with good habits than bad. Let me share a couple of studies with you that might be helpful to put some numbers to this. The first one is a study that was done by Nachemson Advisors. They tried to project what some of the costs would be for physician practices moving towards ICD-10. And they classified those into small, medium, large practices based on the number of providers. Small was, I think, average of 3 providers. Medium was 10. Large practice was 100 providers. Okay, so let's look at the medium practice, for example. You look at the grand total, the total cost, and what you'll see is, man, that's a big number. Well, good news is, for our practice, it wasn't nearly that large. All right, but look at what they also did. They separated it into pre-implementation and post-implementation costs. And look at the costs that are larger. The larger costs are not the pre-implementation costs, it's the post-implementation. Right? This is why I am telling you that October 1st was the starting line, not the finish line for ICD-10. We still have a lot of work ahead of us. And what they put there are the 2 risks that we talked about before. Productivity loss. Right? If you lose that time, you lose it every single day. You can never get it back. It's a recurring cost on some of your most valuable resources in the practice. Right? Your physicians, your PAs, your therapists. But they also show the payment disruption. And where that came from is really the projected increase in denials from the payers. Right? This is the problem that we're talking about. Medicare said that they expect denials to double or triple as a result of ICD-10. Not forever, but you want to be on the low end of that spectrum, right? You want to solve that problem quickly, right, so that you don't pay for that over and over and over again. Another study that was done by the advisory board, and what they did was they looked at Canada's transition to ICD-10. And so what were some of the big costs there? And look what they put front and center, right back to physician productivity. They saw a 10 to 20% decrease in physician productivity in Canada as a result of ICD-10. Right? Now, the good news is none of you have probably seen that in your practice yet. But that doesn't mean that the risk has passed. Right? Just because we're after October 1st doesn't mean that that risk is gone. Because let's get underneath those numbers and understand what was happening. It was an increase in the queries back to the physician, the coders, the billers going back to the doctor saying, I need you to be more specific here. Can you give me more information about this? Can you tell me more about that? Be more anatomically specific. Can you tell me the stage of the disease? What's the healing type for this particular fracture? That back and forth process was costing physicians, on average, 45 to 90 minutes per doctor per day. Even if you cut that in half, that is entirely unacceptable in a busy orthopedic practice. Where are they going to find an extra 22 to 45 minutes per day? Are they going to see fewer patients? Nope. Right? Are they going to try to answer these questions in between visits and get behind in their schedule? Probably not. It's unfair to expect them to answer these questions, these types of coding questions at the end of the day rather than spending time with their family. And it's not what they're like, and it's not what they're good at. So you're going to have the billers, the coders, having to ask several times for this additional information. And so you see the coder productivity declines as well. Now you see a significant decrease at the beginning as they ramp up that learning curve, and they will eventually regain some of that productivity. They'll get back close to where they are today. But they'll probably never get back to full ICD-9 levels of productivity. That's not the coder's fault. That's not the biller's fault. ICD-10 is just more complicated than ICD-9 it was. Okay, and then you look on the far right, the rework productivity, that's the increase in denials that's coming back from the payers. It matches up closely with the Knockomson Advisor study. Again, here when we look at this and start to think about this for your practice, an ounce of prevention is better than a pound of cure. If you can think proactively, if you can make sure your process is working towards this, it'll be much easier to make sure that you're on the low end of the denial spectrum rather than on the high end of the denial spectrum. So how do we do this? How do we make sure that you're using specific ICD-10 codes, or using it as the best codes as possible? We've really seen 3 different approaches by orthopedic practices. So let me share those with you. I'll walk through each of them quickly. The first is to say we're going to hire certified coders, right? We're going to make sure our doctors are documenting at a level specific enough for ICD-10, and then we'll have the coders go through and make sure that they use the right code. Right? The problem there is coders are expensive, and they are getting more expensive. Right? Since we've been working on the transition to ICD-10 for several years, hospitals, health systems have bought up as many coders as they could, and that's driven the price of coders up. And you know, we want to make sure that if you're going to take that route, you want to find the good ones, the ones that have been trained, the ones that have been certified, the ones that have experience coding in ICD-10 for orthopedics. The real issue is, from a return on investment perspective for coders, you've got a double whammy. You've got their productivity declining at the same time that their salary is increasing. So for most organizations, if it didn't make economic sense to have coders in your environment today, for all of your encounters, not just your surgeries, for all of your encounters, it probably doesn't make sense in ICD-10 either. But I did want to mention it because there are people who are using that as their strategy. I see more people do these second two options. The second one is get your doctors to do it correctly in the EHR, right? Assuming that you have one. Get them to do it correctly in the EHR. For some people, that's really easy. For others, that's a bit more difficult. And places that have trouble with their doctors in this regard, it's not because the doctors hate technology or the doctors are non-compliant. It's because the doctors are worried about their productivity. They're worried about their time and how many clicks it takes or how long it takes them to go through this step in their EHR. The challenge for administrators, for billing managers, for project managers is if you heard that complaint in ICD-9, it usually gets louder in ICD-10. Now, you may not have heard this complaint yet, right? Again, because of the way that most EHRs handle ICD-10, it's very easy. Sometimes it can be very easy to select an unspecified code, but requires a bit more work if you want to choose the right code. The way that most EHR vendors I've seen handle this is through a code search process, which doesn't sound problematic. So let me kind of slow down and walk you through that, why some people have problems with that. Everybody expects, we've been trained to expect search to work like Google, right? I mean, Google has become part of our everyday vocabulary. And the way that Google works is you search for something, you type in a short description, you get all the search results, and 99% of the time, the answer that you're looking for is the first choice. That's the magic of Google. Unfortunately, code search doesn't work the same way. You may search for knee pain. If you search for knee pain, you'll get the search results, but search result number one is pain in an unspecified knee. Valid code, but probably not going to produce the outcome, the billing outcome that the practice desires. You search for a fracture, you may get lots of search results that you either have to drill through or read through to choose the one that's most accurate. It's like taking an SAT test and slows the provider down. So you've got to be careful and make sure that you look at your process. Are your users doing that correctly? Is it producing the right type of outcome? Can you take those unspecified codes away? Right? Can you customize that to where they don't have that choice, to where it organizes it for them so that they don't have to read through all of those choices? You need to think about that process, and the more that you can do to think about that now and to plan ahead, the less productivity declines and denials you will see over the next 12, 18 months. Now, the third option, what we've seen a lot of orthopedic practices do is use an electronic superbill, really designed for the doctor's productivity in mind. It can be designed to look exactly like the paper encounter form, so the codes are in the same place. That protects the doctor's muscle memory. It makes it fast for them to use and fast for them to train, and at the same time make sure that the billing team gets the right data that they need the first time downstream. Now, a picture's worth 1,000 words. I'll show you quickly. If it's something you want to talk more about, let me know, and I'll get you in touch with the right person. So what I'm going to do is pull up one of these electronic encounter forms. This is Capture. This encounter form is designed, customized for each practice, right? We make it look the way the practice wants it to look. Sometimes it's different within a practice. You may have a spine surgeon and a lower extremity specialist. They want to see entirely different encounter forms, and that's entirely possible. So let me go through an example and show you how that works. Instead of circle, 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 I'm just going to go click, click, click to do an office visit, a X-ray, and a short arm cast. And you may have other users instead of doctors that are doing this. And then I flip over to the back side, and what you'll notice is it doesn't list out 10,000 ICD-10 codes. What it in fact shows are the familiar ICD-9 codes. This group chose to organize it by joint, and then they've got those choices within each subsection. So let me go through and do just a couple quick examples. When I click on something like plantar fasciitis, right, that's one of those low-risk codes that can convert automatically from ICD-9 to ICD-10. It's just one choice there. When I want to do something like pain in the knee, it cannot convert that automatically. There are places where I have to be more specific. It shows me my choices here for left knee or for right knee. So with one extra click, I can make that selection. Now you'll notice it doesn't show me the choice for unspecified knee in 25.560. It's a valid ICD-10 code, but it's not here because we've customized this pop-up to show only the choices that practice wanted. Click the box, it automatically closes for me, puts in the new code, puts in the new description. Now, those weren't so bad. Let's look at one that's a bit more complicated, like a fracture. This one has 252 choices, right, for the different types of fractures, the different episodes of care. Let's see what that looks like. Does it list them all out, make me scroll through a long list? No. It's organized the new documentation concepts for me so that I don't have to read through all of that. It's defaulted it to the initial episode of care. I'll show you why in a moment. I could change away from that if I wanted to. It takes the type of fracture and puts it here on the vertical axis. Takes the laterality, puts it on the horizontal axis. So it makes it very easy for me to say, up at the Barton's fracture, right distal radius, one extra click, and I'm done. You know, I heard from an administrator in Kansas City who says her surgeons are using this also as a reminder for them. They dictate after each visit, and they used to use the encounter form as a reminder for who they saw, what they did. They still do that. They see this summary section here, but they used a new ICD-10 description as a as-you-go reminder for where I need to be more specific in my documentation. I can't just say fracture distal radius. Now I need to say Barton's fracture, right radius, initial encounter for a closed fracture. Now I've hit all of those elements. I can learn as I go rather than trying to keep up with all of that and go back to a coding class to fill in the parts where I am deficient. And then when that patient comes back in another 30 days for a follow-up visit, let me show you what that might look like. A lot of our clients like to track the historical diagnosis. Because many of my patients are episodic, it makes it easy for me to say, yep, it's a post-op visit, and it's the same 3 diagnoses we did before, plantar fasciitis, pain in the right knee. But that Barton's fracture, right radius, initial encounter for closed fracture, I can't use that again. So instead of showing me all of my choices, it's already whittled them down. It's still a Barton's fracture. It's still the right radius. It's still a closed fracture. But I've got to be more specific about, is it routine healing, delayed healing, non-union, malunion, or sequela? Again, one extra click, closes the pop-up window, puts in the new code, puts in the new description. That's the easiest way we've seen for orthopedic surgeons, orthopedic practices to handle ICD-10, because it makes it easy for the doctor to get to the right code. Many solutions are easy for the doctor, but it may not be producing the right outcome that you need from a revenue cycle perspective. And if you don't get that right outcome, you're going to have billers and coders going back to the doctor. And that's the physician productivity problem we're all trying to avoid. All right, let me spend a few minutes on the revenue cycle side as we start to kind of project out what that looks like over the next 12 months. And then I'll try to answer as many of your questions as I can. So if you do have questions that you want to send in, go ahead and use the questions panel for that, and I'll try to get to as many of them as I can. Because yes, it is, ICD-10 is a big, big change for the physician. And they're going to have to continue to adjust. But it's also a big change for the revenue cycle teams. And as leaders of the practice, you want to make sure that you're looking ahead, that you're making sure that you are avoiding some of those pitfalls, so that we don't have to hire additional staff. Think about it from a very high level. Right now, we're still getting paid for CPT codes, right? We're still in the fee-for-service world. And in that world, you have to have a diagnosis code that makes it medically necessary, right? That's been true for quite some time with ICD-9, and it continues to be true with ICD-10, right? If only billing were that easy and that straightforward. What you have to do once you submit the claim is you play that cat and mouse game with the insurance carriers, right? Everybody's familiar with this. Everybody's done this before. You have to jump through their hoops and hurdles to get the claim paid correctly and completely. And if that weren't enough, they don't all handle it the same way. Blue Cross wants it this way. Medicare wants it that way, right? That makes it very, very challenging. And this is nothing new to you. You've been playing this cat and mouse game for the past 30 years in ICD-9. Now, it's always a moving target, right? Blue Cross, United continue to change the rules on us, but the volume of change is relatively stable, right? That's the challenge. That's the challenge. Many of you probably have a good process in place for how you handle that in ICD-9. You may have notebooks, you may have cheat sheets, right, to remember all of those ins and outs of those rules. The problem is ICD-10 is a huge shift. When we start getting adjudications at the end of October, we're going to start learning all kinds of new changes that have come from the payers. And what are the new hoops and hurdles that you'll have to jump through to get the claim paid correctly? And again, your payers are each going to handle that in different ways at different times. Now, here's the part that's really different. The part that's really different is the payers have never done this before either. ICD-10 is new for them too, and they're going to be learning as they go. And that means they're going to be making changes to their adjudication algorithms. They're going to be changing the cat and mouse game. And they're not going to all do it the same way. They're not going to all do it on the same schedule. But the volume of change will be much greater than anything we've seen in our careers to date. So if that's what the new landscape is going to look like, what we have to ask ourselves is, how are you going to manage those changes? How are you going to keep up with that? Who on your staff is going to keep up with that, right? What types of tools, what types of resources and processes do they need to keep up with that? And maybe the scarier question is, what happens if we don't do a good job of that, right? That's what the new world's going to look like. You want to be prepared. You cannot prevent the changes coming from the payers, but you can make sure that you respond when the changes do come from the payers. What we typically recommend doing for our clients, and anybody can do this, is called a closed-loop denial prevention process. And here's what that means. Again, you can do this in ICD-9. You could do it in ICD-10. It says, I can't stop denied claims. I can't rid the world of new policies from the payers. But here's what I can do. When I see a new denial, when I see a new policy from the payer, I'm going to go back to the beginning of the process. I'm going to figure out what went wrong, what I could have done to have prevented that denial in the first place. And I'm going to build in a new rule to make sure that that doesn't happen again. That way, the next time that exact same scenario occurs, whether it's in 2 hours or 2 weeks or 2 months, that rule is going to fire the same way for all of my employees. Whether it's my most senior certified coder or my newest billing clerk, that protects my organization from if I have any turnover on my revenue cycle team. I don't have that knowledge stored in different silos. That helps me keep up with the payers. That helps me fight back against the payers and make sure that I get my claims paid correctly, that I identify that as quickly as possible. You know, just a quick example of what that might look like using the unspecified example that we used before. just a quick example of how one of our clients handles this. When they see, and this is dummy patient data, so my HIPAA warriors, don't worry about this. For a patient that has United Healthcare, you can see in the middle that they have that diagnosis of M17.9. That's that osteoarthritis of the unspecified knee, right? But down at the bottom, you see the error message, the rule that's firing that says, hey, this is a Blue Cross, this is a, I'm sorry, United Healthcare patient. And United doesn't allow me to use those unspecified codes. And in fact, they're pretty sneaky about it. They don't deny the claim, but they pay us at a reduced rate when we use that code. I need to catch that before the claim is ever submitted, before it's ever posted to my practice management system, so that we can make sure we're maximizing our reimbursement. That's a flexible tool that allows me to respond to the changes that are coming. All right, now I know I went through a lot of that information. I did it very, very quickly. We covered a lot of ground, but I hope that was helpful for you. If there's anything that I can do to help you, or if you'd like a copy of the slides or a link to the recorded version, feel free to reach out. Feel free to let me know, and we'll do the best that we can to help you. But let me stop and answer as many questions as I can for you, so we can make sure that we wrap up on time.